Try getting pregnant. For a person living with severe pelvic pain, those 3 words can sound like medical treatment. They can also carry an enormous private demand about fertility, relationships, work, money, and the shape of a future family. The advice rests on a dangerous confusion. Pregnancy may change endometriosis symptoms for some people, but it does not remove the disease, and it is not a cure. In 2026, a New Zealand survey of more than 600 people with endometriosis found that about 1/3 had been advised by a doctor to become pregnant to relieve symptoms. How did an idea with such weak medical value remain so strong? The answer begins with a body that can appear to improve. Endometriosis happens when tissue similar to the lining inside the uterus grows elsewhere in the body. It is most often found in the pelvis. The tissue can be linked with inflammation, scar tissue, cysts, and organs becoming stuck to one another. Symptoms can include severe period pain, pain outside periods, heavy bleeding, pain during sex, bowel or bladder problems, tiredness, and difficulty becoming pregnant. Some people have extensive disease with little pain. Others have a small amount of visible disease and disabling pain. That mismatch is one reason the condition can be misunderstood. Another is that pregnancy changes hormones and stops menstruation for a time. Some patients feel less pain during those months. A temporary change in symptoms can then be mistaken for treatment of the disease itself, but the lesions have not been reliably removed. Pain can continue during pregnancy, and symptoms can return after birth. The World Health Organization describes endometriosis as a chronic disease with no known cure. Treatment aims to control symptoms, reduce long-term harm, and support the person's own goals. Those goals matter because some common hormonal treatments prevent pregnancy while they are being used. Other care may include pain medicine, physiotherapy, psychological support, or surgery to remove lesions and scar tissue. Fertility treatment may help when becoming pregnant is difficult. These are choices to discuss with a trained clinician. Pregnancy itself is not a prescription. The myth also survived because endometriosis spent generations in a quiet corner of medicine. Period pain was often treated as something women should endure. Symptoms crossed several parts of the body, so a patient might visit one clinician for bowel pain, another for heavy bleeding, and another for fertility trouble. No single visit revealed the whole pattern. Research received less attention than the scale of the condition deserved. When evidence is thin and pain is normalized, a simple story can fill the space. Pregnancy stops periods. The pain may stop. Therefore, pregnancy fixes endometriosis. The first 2 statements can be true for some people, while the conclusion remains false. This is how many medical myths work. They contain a visible effect, then claim more than that effect proves. The idea also offered medicine an easy ending. Instead of building a long-term plan for a complex disease, a clinician could point towards a life event that society already expected many women to want. The patient's pain became mixed with an assumption about motherhood that can be intimidating even when the words are spoken gently. A decision to have a child should not be used as a test of whether someone deserves relief. The scale makes this more than a rare communication failure. Endometriosis affects an estimated 1 in 10 women and girls in New Zealand. That is roughly 120,000 people. Across the world, the estimate is about 190 million women of reproductive age. Internationally, diagnosis can take between 4 and 12 years. New Zealand's own national guidance, published in 2020, calls delayed diagnosis a significant problem. It encourages earlier recognition in primary care, a suspected diagnosis based on symptoms, and management that can begin without waiting for every uncertainty to disappear. That point changes the old story. For many years, people were told that only surgery could provide a definite answer. Surgery can still be important, but modern care can also use a detailed symptom history and imaging such as ultrasound or magnetic resonance imaging. Treatment may begin from a clinical diagnosis before an operation confirms every lesion. The person does not have to wait silently for the disease to become easier to see. There is no single pathway that suits everyone. Someone trying to become pregnant may choose differently from someone who does not want children. A teenager missing school needs a plan shaped around education and family support. A worker losing income during pain flares may need help that includes the workplace. Good care begins by asking what the patient wants their life to contain. It does not begin by assigning them a pregnancy. For a patient, 3 questions can make a medical conversation clearer. What evidence shows that this option treats the disease rather than briefly changing symptoms? What are the alternatives if pregnancy is not wanted, not possible, or not safe? When should a second opinion or specialist assessment be considered? Those questions do not replace medical advice. They return the decision to the person whose body and future are involved. If someone you know still believes pregnancy cures endometriosis, share this distinction with them. Symptom relief is real and welcome when it happens. It is not proof that a chronic disease has gone away. A baby is a person, not a treatment plan.